All right, if you're a clinician who treats patients with colorectal cancer, you know that picking the right therapy is getting more and more complex. So today, we're going to break down the molecular biomarkers that are absolutely essential for guiding those critical decisions. We'll be distilling the key takeaways from the big 2017 Multi-Society guidelines into a really practical toolkit you can start using in your practice right away. So let's start with a question that every one of us has probably faced in the clinic. Imagine you got two patients with metastatic colorectal cancer. On paper, they look almost identical. Same stage, same histology. You give them the exact same targeted drug, but one patient has an amazing response, and the other's cancer just keeps growing. So why? What's going on there? That is the central challenge that really drives this whole field of personalized medicine.
Well, the answer isn't just something you can see on a CT scan. It's actually hidden in the tumor's DNA. It's a specific genetic mutations inside that tumor that ultimately decide whether a drug is going to work or not. And this is exactly where molecular biomarkers become our indispensable guide. Okay, so here's our game plan. First, we'll tackle that personalization problem. Then we're going to dive deep into the two big categories of biomarkers, the predictive ones and the prognostic ones. We'll also see how these same markers can help us screen for hereditary cancer, and then we'll wrap it all up with a really practical guide to testing. Let's get right into it. You know, the old one-size-fits-all approach to cancer treatment is fading, and fast. We now know for a fact that colorectal cancer isn't just one disease. It's really a whole collection of distinct diseases, and each one has its own unique molecular fingerprint. That fingerprint is what dictates how the cancer behaves and, more importantly, what its weaknesses are. Figuring out that fingerprint is the whole key to treating it effectively. So, let's talk about a predictive biomarker. It has one job and one job only. It tells you if a specific drug is likely to work for a specific patient. That's it. It's not about the patient's overall prognosis. It's all about predicting a direct cause and effect relationship between that drug and that tumor. And the classic example in colon cancer is testing to see who should get anti-EGFR therapies. Which brings us to our first major category, predictive markers. I like to think of them as the gatekeepers, because they're the ones who decide which patients get access to some of these really powerful and, let's be honest, expensive targeted drugs. Their job is to answer that one crucial question: will this drug actually work for this patient? Okay, so here's how it works. Imagine the EGFR pathway is like the gas pedal for the cancer cell. It tells it to grow and divide. An anti-EGFR drug, like cetuximab, is designed to block that signal right at the top, like putting a big lock on the front door of a house. But if the tumor has what's called a ROS mutation, it's like a secret switch is stuck in the on position somewhere downstream. The growth signal is already inside the house, running rampant. So in that case, putting a lock on the front door does absolutely nothing. The drug is completely useless. So the bottom line is, we have to check for these mutations. The guideline is crystal clear on this. Any patient who is even being considered for an anti-EGFR drug must get RAS mutational testing. And we're not just talking about the old KRAS exon 2 test anymore. We now know that mutations in other parts of the KRAS gene and in a related gene called NRAS also make the drug ineffective. So this expanded RAS panel, which covers all of these different spots, is now the absolute standard of care. Now let's switch gears to our second category, prognostic markers. I call these the forecasters. They don't tell us if a specific drug is going to work. Instead, they give us a glimpse into the tumor's natural personality. They help us answer the question, regardless of what treatment we give, is this a really aggressive cancer, or is it likely to be a more slow-growing one? One of the most important prognostic markers is called mismatch repair, or MMR status. The easiest way to think about MMR is as a cell's built-in DNA spell checker. Well, in about 15% of all colorectal cancers, that spell checker is broken. We call this condition deficient mismatch repair, or DMMR. And that 15% is a huge group of patients whose tumors behave in a very, very different way. And here you've got a tale of two completely different stories that every clinician needs to know. On one hand, tumors that are DMMR, the ones with the broken spell checker, they generally have a better prognosis, especially in earlier stages. It's actually a good sign. But on the absolute opposite end of the spectrum is the BRAF V600E mutation. If you find this mutation, it's a major red flag. It signals a much poorer prognosis and a far more aggressive cancer. And I'm not exaggerating here. This isn't a subtle thing. The evidence laid out in the guideline is just overwhelming. For a patient with metastatic disease, having a BRAF mutation is one of the single worst prognostic factors we know of.
Knowing this information up front is absolutely vital for managing expectations of your patients and for thinking about maybe more aggressive treatments or clinical trials right from the start.
Now, these biomarkers have this third, really fascinating role. See, when you find a tumor that has deficient mismatch repair, you have to ask yourself a critical question. Why is it deficient? Is it just a random one-off event in an older patient? Or is it the very first clue that this patient might have Lynch syndrome, which is the most common cause of hereditary colorectal cancer?
So let's just walk through this really clever algorithm from the guidelines. Okay, step 1. Your pathology report comes back and shows dMMR because a protein called MLH1 is missing. Step 2. Your next move is to test that exact same tumor tissue for a BRAF V600E mutation. Now this is the crucial fork in the road. If the BRAF mutation is there, if it's present, then the dMMR is almost certainly sporadic. It's not hereditary. You can stop the workup. But if that BRAF mutation is absent, then Lynch syndrome is a very real possibility, and that patient absolutely needs a referral for genetic counseling. All right, let's wrap up by getting into the real nuts and bolts of all this. What you actually need to know when you're ordering these tests for your patients in the clinic. A question I get all the time is, which piece of tissue should we test? Well, the guideline says that tissue from a metastasis is preferred, if you can get it safely. But, and this is so important, the original primary tumor is a perfectly acceptable alternative. And the reason for that is that the concordance, or the rate of agreement, for these key mutations like RAS and BRAF between the primary tumor and where it spreads is incredibly high. We're talking well over 90%. In oncology, time is everything, right? So the guideline sets a pretty clear benchmark. You should expect to see these reports back within 10 working days of the lab getting the sample. That's really the turnaround time that you should be pushing for at your own institution. Now here's a quick technical detail, but it's super important. Your tumor sample is never pure tumor. It's always mixed with some normal cells. So a good test has to be sensitive enough to find a mutation even if it's hiding in just a small fraction of those cells. The guideline sets the bar at a 5% mutant allele frequency. This basically ensures we don't miss a critical mutation and end up giving a patient a drug that has no chance of working. So, to wrap it all up, these few biomarkers play 3 really distinct and vital roles in the clinic. First, RAS testing is predictive. It's our gatekeeper for anti-EGFR therapy. Second, BRAF and MMR status are prognostic. They're our forecasters for the disease's likely outcome. And third, MMR and BRAF testing work together as a hereditary screen, helping us find those patients who might have Lynch syndrome. And that really brings us to what's next on the horizon. I mean, we've gotten really good at using this core set of biomarkers, but next-generation sequencing is uncovering dozens more. So the big challenge ahead isn't just about finding new markers, it's about figuring out how to weave all of these complex molecular details together into one single coherent treatment plan for every single patient. That, right there, is the next great frontier of personalized oncology.